Good evening, our respected professors, doctors, ladies and gentlemen. Welcome to our B-Fluid product launch event. My name is Dr. Imo, and it is my great honor to serve as MC for this evening. Today, we are here to explore the latest in perioperative fluid and nutritional management, hear from our distinguished professors, and learn how B-Fluid can support better patient outcomes. Before we begin, let me briefly introduce the program for this evening. We are honored to have two chairmen for this session, Professor Tung Wu, retired professor and head of surgery department, University of Medicine 1, and then Professor THEIN, consultant gastroenterologist, patron of Myanmar Gastroenterology and Liver Society, and Consular Asian Pacific Society of Digestive Endoscopy. We will start with an opening speech by Professor Tung Wu, followed by three distinguished presentations by our respected speakers. Our first presentation is titled Current Practice and Challenges in Perioperative Fluid and Nutritional Management. This session will be presented by Professor Sen Yi, professor at Yangon General Hospital. Then, Associate Professor Sui Momya from the Department of Gastroenterology, Yangon General Hospital, will speak on nutrition management in inflammatory bowel disease. Our final scientific presentation will be optimizing perioperative recovery through balanced fluid and nutrition. Clinical experience from Indonesia will be presented by Dr. FRANSISCUS ARIFIN. After all the presentations, there will be a Q&A session followed by a product presentation. Finally, we will have closing remarks by Professor THEIN, and we invite you to enjoy dinner afterwards. So without further delay, may I kindly invite our Honorable Chairperson, Professor Tung Wu and Professor THEIN. Please welcome to our Chairperson to the stage. And may I respectively request our Professor Tung Wu to deliver the opening speech. Yeah.
Good afternoon, distinguished guests, my colleagues, and my and all my colleagues. It is indeed an honor for me to act as a chairperson in this scientific symposium together with my colleagues, Professor THEIN. So today is a special day. It's a different kind of symposium usually running around in this country. So as an introduction, for us, for a person to be in good health, our organ system has to function very well. For our organ system to function very well, our cells have to function very well. For our cells to function very well, they need a good internal environment. That's what we call homeostasis. So this internal environment homeostasis includes this blood, plasma, interstitial fluid, limbs, and tissue fluid, etc. So these parameters are also measured and controlled, like temperature, pH, glucose level, electrolytes, oxygen, and fluid balance. So all these parameters must be in optimized condition for the cells to function normally, especially in the post-operative period. So surgery disturbs the organ, our body very much. So today, the three distinguished speakers are going to talk on this perioperative fluid and nutritional management. So, so we are going to hear a special talk from three experts today. So I'm handing the floor back to this Master of Ceremony.
So let me proceed to our first presentation. Our first presentation title is Current Practice and Challenges in Perioperative Fluid and Nutritional Management, will be presented by Professor Sai. So Professor Sai, please welcome him to the stage.
Good evening, ladies and gentlemen. Today, I would like to discuss a very controversial issue that is very important, which is perioperative fluid and nutritional management. If we can optimize perioperative fluid and nutritional management, we can ensure the best outcomes in surgery. First of all, I would like to discuss the perioperative fluid management. Clearly, our goal is to maintain central euvolemia to have a nice circulation, which means to have a safe delivery of oxygen to the tissue. Basically, in major surgery, there is significant SIRS and increased demand of oxygen to the tissue. So, perioperatively, if we can optimize, perioperatively, we have to find out the possible causes of tissue hypoxia, and we have to solve these causes by perioperative fluid management. Regarding with fluid management, there are two simple questions that are relevant here. Which type of fluid we should use and how much fluid we should give. Amount of fluid to be administered has always been more difficult and controversial than the type of the fluid because very few studies are available covering the different types of surgery and different patients. During the perioperative periods, these studies are not uniform and we don't know how much fluid should be given during the perioperative period. Generally, in minor surgery, we usually give 1 to 2 liters of fluid perioperatively, mainly crystalloids. The rationale behind is to correct dehydration, thereby reducing post-operative complications such as drowsiness, dizziness, nausea, vomiting, and post-operative pain. In major surgery, we do have 3 strategies, which are standard approach, restricted approach, and goal-directed therapy. In standard approach, we aim to replace the fluid loss, including the fluid loss to the thigh space, which means fluid shifted from the intravascular compartment to interstitial compartment during the perioperative period. So we give so much fluid, so post-operative weight gain is usually 3 to 6 kilograms. Thigh space loss does not occur in all patients, especially healthy patients and in minor surgery. Because of excessive fluid replacement, there is intravascular hypervolemia. Because of intravascular hypervolemia, it release of atrionatriuretic peptide and the degradation of glycocalyx, which increase the vascular permeability. Because of increased vascular permeability, there is tissue edema and organ dysfunction. In restricted approach, thigh space loss is not counted on. All measurable fluid losses plus sweating, evaporation, and respiration, insensible loss are replaced appropriately. The term restriction is very confusing. Some people thought restricted approach is associated with hypovolemia, but it's not. Completely, actually, it is a zero balance. A comparative study between the restricted approach and standard approach. Restricted fluid regime was not associated with higher rate of disability-free survival than the standard approach. But we can see that standard approach is not the good one because of excessive fluid replacement. Let's move on to goal-directed therapy. What is goal-directed therapy? It is a personalized hemodynamic management. Goal-directed therapy is a complex strategy of fluid infusion aimed at optimizing tissue perfusion and oxygenation. guided by hemodynamic variables. It allows physicians to administer fluid and or use other therapies such as inotropes or vasoactive drugs. There are two questions. How can we measure the response to fluid challenge? And how can we predict if the patient is going to be fluid responsive and benefit from fluid challenge? In my opinion, both are equally important. We will need the minimally invasive technique. There is a esophageal Doppler ultrasound. We have many other invasive and non-invasive techniques. There are many advantages of goal-directed therapy in major surgery, like reducing incidence of post-operative complications, improve wound and anastomotic healing, and reducing the length of hospital stay. The main drawback is that the minimally invasive cardiac output monitor should be considered in all patients with major surgery to optimize the preload. In our country, it would be the limited option. Major surgery more than 1 hour. Major surgery with anticipated blood loss more than 500 ml. Major intra-abdominal surgery, intermediate surgery in high-risk patients. And, patient with ongoing evidence of hypovolemia and or hypoperfusion, they can benefit from goal-directed therapy. In this trial, it didn't provide the evidence that cardiac output-guided hemodynamic therapy with low-dose inotropic infusion could reduce the incidence of post-operative infections. How to make it balanced? Although restricted and goal-directed therapy shows superiority to standard approach, we need to make a balance between them. Let me highlight it again. We need to make a balanced approach with our patients. There is, in other words, is a personalized approach. For example, 1 to 2 hour laparoscopic surgery in healthy patients. Restricted approach is preferable. For patients with major surgery, goal-directed therapy is the one to go. Miller and colleagues suggested how to make a balance between these approaches. Please have a look at the diagram. You can see that choice is guided upon the level of risk and types of surgery. Now I'm going to talk about the type of fluid, which is also very important. Fluids are mainly used for two purposes, which are maintenance fluid and resuscitation or volume therapy. For maintenance fluid, patients who cannot take sufficient volume of fluid enterally, they should be given maintenance fluid. For calculation of maintenance fluid, we should consider daily maintenance volume, daily electrolyte requirement, daily glucose, which need to counter starvation ketoacidosis. For obese patients, calculation is based on ID body weight, usually not more than 3 liters per day. For children, we would calculate according to Holiday and Seeger formula. For patients with heart failure, renal impairment, and malnourished patients, it is usually about approximately 20 to 30 ml per kg per day. These are just basic facts to recall. Now I will touch a little bit on type of fluid and how we will make a good choice. Choice of fluid is also area of controversy. As you all know, we do have two main types, crystalloids and colloids. Crystalloids are water plus electrolytes or water-soluble molecules. They are well known for their simplicity, cost effectiveness, and no immune response. On the other hand, colloids are large insoluble molecules providing high osmotic pressure within the blood. They are rather expensive and they have potential complication with immune system. There is ongoing debate between crystalloids and colloids, but sometimes HES is preferred due to lower volume needed for infusion. For most patients, moderately hypotonic dextrose-containing solutions with adequate electrolytes are used. During surgery, isotonic crystalloids are mainstay of choice so far. Balanced solutions are preferred over normal saline because saline is associated with hyperchloremic metabolic acidosis, renal vasoconstriction, and renal injury. Now I will discuss a little bit on perioperative nutritional management. Optimal nutritional status is one of the key factors in reducing perioperative complications and improving outcomes. Metabolically active tissue, such as brain, renal medulla, red and white blood cells need constant supply of glucose. 24 to 40 hours after fasting, body glycogen stores are usually depleted. Any surgery, how minimally invasive state is trauma to the body. So there is a metabolic response to trauma and sepsis. Metabolic response to trauma is influenced by early and rapid rise in sympathetic nervous system activity, circulating catecholamines, elevated glucocorticoids, glucagon, growth hormone, and insulin. Its responses include increased energy demand, increased nitrogen requirement, increased insulin resistance and glucose intolerance, loss of adaptive ketogenesis, and fluid retention with hypoalbuminemia. Effect of metabolic response to surgery on nutrition is affected not only by induced fasting period, but also by the phenomenon of increased insulin resistance. All of these can be augmented by triggers of pain, impairment of homeostasis, tissue damage, and tissue hypoxia. Stress hyperglycemia can occur as a result of increased gluconeogenesis, reduced peripheral glycolysis, reduced transport of glucose into the cells, reduced activation of glucose receptors. Because of lack of response to insulin, there is the increased insulin resistance can lead to catabolic response with loss of lean muscle mass. Therefore, inadequate nutritional support in the perioperative period can lead to delayed wound healing, impair immune function, and interfere with heart, liver, and kidney function. So providing adequate calories, proteins, vitamins, and trace elements are very important. How can we assess the nutritional status? It is usually by ABCD, which are anthropometry, biochemistry, clinical evaluation, and dietary. Anthropometry is quite simple, but it's not accurate enough to learn for nutritional support regimes. We can measure weight and percent weight change, body mass index, mid-upper arm circumference, tricep skin fold thickness, and mid-arm muscle circumference. Biochemical parameters are used in conjunction with history and clinical examination. Here are most commonly used markers. They are hemoglobin, albumin, C-reactive protein, hemoglobin A1C electrolytes, and micronutrients level. Clinical evaluation is also important for us. We look for upper GI symptoms such as nausea and vomiting, early satiety, dysphagia, and reflux or bloating, and lower GI symptoms such as diarrhea or constipation, which are taken into account to calculate the nutritional status. Basically, daily calorie requirement is 25 to 35 kilocalories per kg, but metabolic stress and activity level need to be considered. I will highlight the point: patients who eat little or nothing for over 5 continuous days are likely to require nutritional support. MAS is commonly used as dietary assessment tool. What is MAS? It is a malnutrition universal screening tool. Please have a look at the diagram. We can give scores based on body mass index, weight loss, and disease effect. Score will give the clear vision of nutritional status of the patients so that we can treat accordingly. Patients who are unable to consume enough, they will need either enteral or penetrant nutrition. Patient condition, weight, and nutritional status will give guidelines to formulate or choice between enteral and penetrant nutritional support. Enteral nutrition is always preferred over penetrant nutrition. I won't touch these slides in detail. These slides are about the calculation of macronutrient requirements, calculation of carbohydrate and protein, and coagulation of fat, vitamins, minerals, and trace elements. What I would like to focus is about the effects of intestinal recession. Effects of intestinal recession can occur as a result of surgical recession or reduction in functional capacity by inflammatory bowel disease, such as Crohn's disease and ulcerative colitis. Effects of intestinal recession depend on site and extent of affected bowel. Patient may need supplemental parenteral nutrition, IV fluid, or both. As the ileum is responsible for absorption of bile salts, loss of even 100 centimeter can lead to steatorrhea. If the remaining intestine is less than 200 centimeter, it is known as short bowel syndrome. Patients with short bowel syndrome will need parenteral nutritional support, definitely. This is the demonstration of how we can give artificial nutritional support to our patients. For enteral nutrition, oral feeding, or nasogastric, nasoduodenal, or nasojejunal tube feeding. For the tummy, gastrostomy tube or jejunostomy tube feeding. For parenteral nutritional support, either total parenteral nutrition or peripheral parenteral nutritional support. Nutritional support is not one-day tasks. It needs continuous monitoring by clinical assessment and biochemical parameters. How frequently we should monitor is according to clinical assessment and biochemical parameter results. Some should be observed daily, some weekly to fortnightly, and some 3 to 6 monthly. Parenteral nutritional support is not without risks. We should be aware of complications of parenteral feeding, such as insertion complications like pneumothorax or misplacement, line complications like sepsis or thrombosis, and metabolic complications like electrolyte disorders, including refeeding syndrome, blood sugar derangement, liver dysfunction, and vitamin deficiencies. What about the EROS protocol? For each and every surgical procedures, there are many EROS protocols to follow. They are highly recommended because they are evidence-based and multidisciplinary, thereby improving the surgical outcomes and reducing the healthcare costs. EROS has many components. One critical component is perioperative fluid management. Goal-directed therapy with EROS is certainly beneficial. Another important component of EROS is nutritional support. For patients with elective surgery, preoperatively, avoid prolonged fasting. You can give solid food 6 hours until 6 hours and clear fluids until 2 hours before surgery. Preoperative carbohydrate loading, there is a clear carbohydrate solution until 2 hours before surgery to reduce the insulin resistance. Nutritional screening and optimization, especially in malnourished patients. Consider immunonutrition such as omega-3 and arginine, especially in major surgery. Intraoperatively, avoid excessive IV fluids. Maintain normothermia to reduce the metabolic stress. Postoperatively, early oral feeding, that is within the 24 hours, even in major gastrointestinal surgeries. As I mentioned before, enteral nutrition is always preferred over parenteral nutrition. Parenteral nutrition should be considered if enteral feeding is inadequate or contraindicated. Finally, a doctor's life is all about how to handle the challenges. Regarding with fluid therapy, challenges are we can accurately evaluate blood volume. We can quickly identify fluid overload. We can accurately recognize hypovolemia. We can accurately evaluate tissue perfusion. Research are going on and on. They have given us some insights to many questions. However, questions remain incomplete. How is perioperative fluid management influenced by type of surgery, by intercurrent treatment, and by underlying disease? Should perioperative fluid management be based in a prescribed dose, or should it be given to attain certain physiologic goal? If physiologic goals are preferred, which goals should be used? Nutritional therapy also gives us a lot of challenges. Multidisciplinary team approach is the best, which include doctors, dietitians, special nurse, or pharmacists. Recognition of early signs of complication is key factor. Safe administration, timing of start, when to stop, and when to wean is challenging. Practically, it is difficult to solve some challenges. Multidisciplinary team specialists are not always available, as well as some types of nutritional support and fluid. There are many barriers to do health education and moral support. Last but not the least, it is cost that always limit our choice of treatment and patient care. In highlights of importance of perioperative fluid and nutritional management, our decision, our choice can change the outcome, and this must be knowledge-based and experience-guided. That we should consider the individualized treatment and care. The choice of approach is surgeon-specific, patient-specific, and institution-specific. Thank you. Thank you very much.
Thank you, Professor Sengyi, for the insightful presentation. So may I now invite our chairperson, Professor THEIN, to the stage to introduce the second speaker.
Good evening, everyone. I am very happy to introduce the second speaker, Professor Suimomya. She is a consultant gastroenterologist working at the Yangon General Hospital, University of Medicine 1. She finished her master's degree of internal medicine last 20 years ago. After that, she joined to gastroenterology. She worked in gastroenterology field for more than 15 years, doing a lot of endoscopy and inpatient and outpatient care. Her special interest is ERCP and EUS. For research purpose, a special interest in H. pylori and inflammatory bowel disease. Today, she will discuss about nutritional management in inflammatory bowel disease. Please welcome Professor Suimomya.
Good afternoon to respected chairpersons and dear colleagues. I'm very honored to be here to participate in this scientific symposium. My topic is the nutritional therapy in inflammatory bowel disease. As you all know, the inflammatory bowel disease is now increasing in our country. That despite the optimal medical therapy, many patients with inflammatory bowel disease still experience malnutrition, protein energy malnutrition, and micronutrient deficiency, and poor quality of life. So today's topic will talk on the nutritional therapy as a practical solution for these challenges. These are the outlines, and I will touch on the following topics. The first is the global prevalence, and then the Myanmar data, and the pathophysiology related to diet, and how we should do the nutritional assessment in inflammatory bowel disease. And then I will talk on the diet therapy and nutritional therapy for inflammatory bowel disease. And let me start with the global prevalence. This is the green area, including the Myanmar and the Africa. We have the emergence incidence of the inflammatory bowel disease. And then the yellow one is the acceleration in incidence. So the total affected population worldwide is 3.8 million people, and the global prevalence rate is nearly 229 per 100,000 populations. In the ulcerative colitis, there is a 120 cases per 100,000 population. In Crohn's disease, it's 84 cases per 100,000 population. So how about the Myanmar data? We don't have the actual incidence for the whole country, but in our Department of Gastroenterology, Yangon General Hospital Registry, in 2025, we have 65 cases of inflammatory bowel disease, in which the ulcerative colitis is 44 cases and Crohn's disease is 21 cases. So what about the inflammatory bowel disease etiology? It consists of the extrinsic factor and intrinsic factor. In extrinsic factor, there may be the air pollution, medication, sleep quality, physical activity, smoking, diet, and the breastfeeding. So we can modify these extrinsic factors to prevent the inflammatory bowel disease. And the intrinsic factor is the genetics, immunological status, and gut microbiome. Another is what about the pathophysiology of the IBD related to food? In the normal individuals, when we eat the food healthy diet, together the healthy food interact with the host microbiomes, and it can produce the short chain fatty acids, which are very good for the intestinal lumen and can maintain the normal function of the gut. When there is ulcerative colitis and Crohn patients, there may be the pathogenic bacteria. They can interact with the saturated fatty acids and the sugar, and they cause the damage to the villi, which can cause the leaky gut and can cause the inflammations, which can cause the ulcerations and impair the intestinal absorption. So what is the impact of the intestinal inflammation on the nutritional status? So intestinal inflammation can impair the nutrient absorption. Firstly, by the following mechanism, it can damage the villi and microvilli, which are very important and crucial for the absorption of the nutrients. This causes the structural loss and they significantly reduce the absorption of the macro and micronutrients. It impairs and disrupts the tight junctions, and it causes the leaky gut. And then the microbial products and toxins to be translocated into the systemic circulation, and it activates the inflammatory cytokines and cause the impairment of the nutrient transport. Inflammation not only damage the villi, it induces the dysbiosis. It decreases the abundance of the normal intestinal bacteria flora. This imbalance compromises the microbial fermentation, the production of the short-chain fatty acids, and synthesis of the essential vitamins. Or inflammatory cytokines like the tumor necrotic factor and interleukin-1 beta downregulate the expression and function of the nutritional transporters, such as the glucose transporter, amino acid, and fatty acid transporters. So in Crohn's disease, Crohn's disease can affect the all GI tract, including the stomach, small bowel, and large bowel. So affecting the small bowel can lead to the impairment of the absorption of the vitamins like the vitamin B12, fat-soluble vitamins, calcium, iron, and proteins. In the Crohn's disease, malabsorption is less common because in the ulcerative colitis, malabsorption is less common because it usually affects the colon. So vitamin D, calcium, and iron can only be affected. So these are the endoscopic features of the ulcerative colitis and Crohn's disease. In the early stage of the ulcerative colitis, there is a loss of vascular pattern with the mucosal friability, granularity, with the superficial ulcerations, deep ulcerations, and luminal hemorrhage. And finally, this can lead to the scarring with the pseudopolyp formation. This is the endoscopic features of the Crohn's disease. This is the small bowel. This is the normal small bowel. In the Crohn's disease, there is an ulcer, maybe the deep ulcer, which can cause the strictures in the small bowel. And this is the endoscopic features of the Crohn. It's the typical aphthous ulcer of the Crohn. There may be the deep linear ulcerations, which lead to the typical gallstone appearance. So the how common is the nutritional complications in the inflammatory bowel disease? Malnutrition accounts for the 20 to the 85%, in which the protein energy malnutrition is very common. In active inflammatory bowel disease, it is 75%. These IBD patients are higher risks of the micronutrient deficiency, like the vitamin A, B6, B12, D, K, and minerals, iron, zinc, and calcium, and selenium. It usually caused by the diarrheal, malabsorption, intestinal failure, and inadequate dietary consumption, secondary to anorexia. So, together with the acute intestinal inflammation, this can lead to the increase in the basal energy, protein catabolism, anemia, osteoporosis, thrombophilia, poor wound healing, and exacerbation of the chronic inflammation, and finally lead to the carcinogenesis. So it is important to assess the nutritional assessment in inflammatory bowel disease. We should do by the 5 steps. And the step 1 is the nutritional screening by using the malnutrition universal screening tool. If the screening tool shows the high risks, we should proceed to the ABCD. And the step 2 is the anthropometric assessment. And the step 3 is the biochemical assessment by doing the blood investigations like the blood for complete picture, inflammatory markers, and other vitamins and nutrients. And the step 4 is the clinical assessment by history and physical examination. And the step 5 is the dietary assessment by asking the patient to write the food diary. After doing the nutritional assessment, we should give the diet therapy to the inflammatory bowel disease patient. There are the many diet therapy in inflammatory bowel disease, and the most important one they recommend is the Mediterranean diet. So Mediterranean diet can lower the risk of the cardiovascular disease and the chronic conditions. This diet consists and process anti-inflammatory and the promoting the diet rich in the microbiomes, lean protein, and omega-3 fatty acids. This diet can stimulate the production of the short-chain fatty acids, which is good for the GI symptoms, and it can regulate the inflammation and immune response. So what is the diet of the Mediterranean diet? So it consists of we can enjoy the daily of the whole grains, fresh fruits and vegetables, beans, herbs, spices, nuts, and healthful fats. It is an olive oil and fat from the avocado. We can enjoy daily. We can enjoy fish and seafood 2 times per week. And we can enjoy the dairy products, eggs and poultry moderately. And we should avoid the red meats and the artificial sweets and the preservatives. So why it is so important to do the Mediterranean diet? How it can give the beneficial effects? So for the IBD prevention, for the general population, it can reduce the Crohn's disease onset, and it can reduce the inflammatory markers, and it can increase the microbiomes and short-chain fatty acids. For the first-degree relatives, it's also reduce the inflammatory markers and it increased the microbiomes, and it increased short-chain fatty acids. So what about the impact on the IBD? So the many studies said that the Mediterranean diet can reduce the remission in the Crohn's disease, especially in the pediatric population. And it can disease activity, inflammatory markers, and it maintain the inflammatory markers in the remission period. So the patients with the IBD, by having the Mediterranean diet, it increased the quality of life, it reduced the liver steatosis, it can increase the high density lipoprotein, and it increased the short chain fatty acids. So they usually recommend the Mediterranean diet for the inflammatory bowel disease. So what about the other diet? The second one is the dairy-free diet. It is the topic of controversy because the milk and milk products contain the sulfur-containing products. It increases the hydrogen sulfate in the intestine, and which can lead to the intestinal inflammation. Another is that it can cause the lactase deficiency. It prevents the proper absorption, and it triggers the bacterial fermentation, leads to the abdominal inflammation and diarrhea. But the total abstinence of the milk and milk products can lead to the calcium and vitamin deficiency because the many patients of IBD, we usually prescribe the steroids because the steroids can cause the osteoporosis. So we should aware that the too much restriction can lead to the osteoporosis. And another study is Kefir diet, and the Kefir diet is a fermented milk. It regulates gut microbiomes, and it improves the abdominal pain and intestinal inflammations. So what about the high fiber diet? And the high fiber diet include the insoluble fibers and the soluble fibers. They usually recommend the soluble fibers because insoluble fibers can cause indigestion, bloating, and sometimes they lead to the diarrhea. Fibers like the inulin and belly fibers reduce the inflammatory bowel disease activity score. Specifically in Crohn's disease, it lowers the disease activity. But in the ulcerative colitis, high fiber diet found no association between the disease activity. So another diet is an anti-inflammatory diet. An anti-inflammatory diet have 5 main aspects. They reduce the monosaccharides, disaccharides. They increase the consumption of the pre and probiotics. They have the healthy fats. They identify the nutritional deficiency. So recognizing the food intolerance. So anti-inflammatory diet is limiting sodium, sugar, red meats, processed meats, additives, alcohol, and ensuring the diet is well balanced. So the anti-inflammatory diet is also very popular in the management of the inflammatory bowel disease. So another is a low FODMAP diet because a high FODMAP diet are poorly absorbed in the small intestine, and they can lead to the osmotic effect and draws water in the lumen. So low FODMAP diet is most significant benefit in IBD patients overlap with the symptoms of the irritable bowel syndrome and some functional digestive disorder and the early stages of IBD. So this is the dietary management based on the bowel function and disease activity according to the Bristol stool chart. So it is a green is the best. So when the patients have this type of stool, so his diet, he can maintain his diet, and that this is this orange is not good. So this is the constipation. So they encourage the increased intake of the fresh fruits and vegetables. And this orange one is also the semi-solid and watery. So this is the increased activity of the inflammatory bowel disease. So the treatment is necessary. So in the active phase of the inflammatory bowel disease, low residue diet is usually recommended. So what is low residue diet? It is a well-cooked food that have low in insoluble fiber and free of irritants, such as they usually recommend the bland preparations such as rice, mashed potatoes, cooked carrots, wild chicken, and stewed fruit. This low residue diet can reduce the fecal volume and minimize the intestinal stimulation and improve the digestive tolerance. In severe cases, we should give the enteral nutrition. And another important one is the non-recommended diet. The patient should avoid the following diet, especially the ultra-processed foods. Ultra-processed foods are the non-caloric sweeteners, additives, artificial flavors, added sugars, stabilizer, emulsifiers, and the preservatives. All can lead to the intestinal inflammation and the activation of the inflammatory bowel disease. Another diet they should avoid is the Western diet. And the Western diet is the large amount of ultra-processed foods and the red meat and the sugary beverages, sweeteners, fried items, and conditionally animal products. So they should avoid. So these are the summary of the diet therapy for the inflammatory bowel disease. So the best one is the green one are the best, and the Mediterranean diet, dairy-free diet, and anti-inflammatory diet are the best. And then the high fiber diet, they can use, but we should caution in patients with the inflammatory bowel disease with the strictures because insoluble fibers can lead to the intestinal obstructions. So the patients should avoid the Western diet and ultra-processed food diet. So another topic is the nutritional support in the inflammatory bowel disease. So nutritional support should be initiated in patients with oral intake is insufficient for nearly 7 days in case of the preoperative malnutrition, short bowel syndrome, high output fistula, or severe malabsorption. So in general nutrition management, basic energy requirement depends on the BMI, and we should take cautions in severely malnourished patients, especially BMI less than 18 because high risk of refeeding syndrome. In these patients, we should monitor the micronutrients, potassium, magnesium, and phosphorus because it can cause some disturbances. So we should start with the 25 to 50 of the estimated calorie, and we should increase gradually over 3 to 5 days. So what about the protein? The protein requirement in active IBD is 1.2 to 1.5 gram per kilocalorie per day in adults. So in patients with the prolonged IBD, we should check for the micronutrient deficiency. So we should give the folic acid, calcium, and vitamin D, and fat-soluble vitamins, and the vitamin B6 when the patient is on the isoniazid. So let me start with the enteral nutrition. So we can give the enteral nutrition. These are the enteral formula. There may be the polymerit type, semi-elemental, and elemental types. And enteral nutrition can give by the nasogastric tube or percutaneous endoscopic gastrostomy tube. Depends on the patient's tolerance and the duration of treatment. The standard polymerit formula with a moderate fat content is usually recommended. In our country, we only have the Ensure and other brands are not available. in our country. So in enteral nutrition is as effective as the steroid therapy in inducing remission in 73% of the pediatric patients with the Crohn's, but not in the adults. But to give the enteral nutrition, the patient digestive system is functional, and it may be the exclusive enteral nutrition or partial enteral nutrition, depends on the patient's condition. So what is an exclusive enteral nutrition? An exclusive enteral nutrition, EEN, we can give by mouth or by feeding tube, usually with the liquid form. So in our country, we can only give the ensure. So 100% calorie intake is only consumed by the oral supplement. It may be the polymeric formula, not usually to give the elemental formula. Another is the partial enteral nutrition. So PEN is recommended in some patients, especially in the Crohn's disease. It's the Crohn's disease exclusion diet. They can divide into the phase 1, 2, and 3. This is the examples of the food usually given in the partial enteral nutrition for the Crohn's disease. And another nutritional therapy is the parenteral nutrition. And the parenteral nutrition is especially used in the Crohn's disease with severe complications and the selected cases in the ulcerative colitis. And the parenteral nutrition is recommended when the enteral nutrition is not possible because of the short bowel syndrome, high output fistula, and intestinal obstruction. And the patients with the severe GI bleeding. So there are the two types, the peripheral parenteral nutrition and the central parenteral nutrition. In peripheral parenteral nutrition, osmolarity is the less than 900, and it limits the use because it can be used less than 10 to 14 days. Central parenteral nutrition is we can give the hyperosmolar solutions by giving the catheter. So these are the summaries for the nutritional therapy. So we should assess whether the patient is a functional digestive tract. If patient have the functioning digestive tract, we can start the enteral nutrition. If the patient doesn't have the functioning digestive tract, we should start the parenteral nutrition. So the less than 6 to 8 weeks duration, we should give the nasoenteric tube. More than 6 weeks, we should give with the ostomies, by the gastrostomies, nasogastrostomies, or the jejunostomies. The formula may be the isotonic, polymetric, or the standard types. If the patient can tolerate, we can lead to the oral nutrition. So what about the parenteral? It's less than 2 weeks, we can start with the peripheral parenteral nutrition. And if patient needs for more than 2 weeks, we can start with the central nutrition. If the patient can tolerate, we should change to the enteral nutrition. So what about the probiotics in inflammatory bowel disease? So the probiotics should not be used in the active Crohn's disease. So what about the ulcerative colitis? We can use the Lactobacillus reuteri and VSL3 for the mild to moderate ulcerative colitis. So this is the American Gastroenterology Association recommendation for the clinical nutrition therapy in the inflammatory bowel disease. When the patient have the inflammatory bowel disease, we should advise him to take the Mediterranean diet. When the patient have the strictures, they should take the soluble fiber, cooked food, and the mesh food, and the chew well. When the patient have the inflamed Crohn's disease, exclusive enteral nutrition is preferable. It can induce the clinical remission and endoscopic remission. So the preoperative and malnourished inflammatory bowel disease patient, we should both both we can use the exclusive enteral nutrition and the parenteral nutrition, and then we can go ahead to surgery. What about the abscess? Abscess, when the patient have the abscess, we should nothing by mouth and the parenteral nutrition and then the surgery. So what about the high output fistula, prolonged ileus, short bowel syndrome, severe malnutrition? So we should give the parenteral nutrition. Similarly, the short bowel syndrome, we should use the parenteral nutrition, IV fluids, and then we can change to oral when the patient is stable. So to summarize my presentation, so in inflammatory bowel disease, the nutritional assessment is a fundamental. We should have the 5 steps assessment, and the multidisciplinary team approach is quite important. Gastroenterologists, surgeons, dietitians, psychologists, and the nurses are very important. And evidence supporting diets such as Mediterranean diet, dairy-free diet, anti-inflammatory, and high-fiber diet are effective strategies. And if patient cannot tolerate the oral food, we should consider for their enteral and parenteral nutrition, depends on the patient's clinical condition. And thank you for your kind attention.
Thank you, Associate Professor Suimomya, for your excellent presentation. As we came to the end of academic session, I would like to invite our chairperson, Professor Tong Wu, to the stage to warmly welcome to our final speaker.
That speaker is from Indonesia, so he's a honored guest, Dr. FRANSISCUS ARIFIN. So he's a head of surgery department. It's Suwandi General Hospital, Surabaya City, and he's a chief of quality improvement and patient safety committee. It's also from Suwandi General Hospital, Surabaya City. It's a clinical instructor in postgraduate surgery program and in Indonesia Digestive Surgeon Association. So also secretary of the International College of Surgeons Pacific Federation. And he's also member of International Hepatobiliary Association. He's also a lecturer and lecturer at Faculty of Medicine, Vidya Mandala Catholic Universities. He's going to talk on optimizing perioperative recovery through balanced fluid and nutrition. It's clinical experience from Indonesia. Dr. FRANSISCUS ARIFIN, please.
Okay. Good afternoon, and thank you for the opportunity to speak. It's an honor for me to be able to speak in this forum. I think I will just share my experience in using the product that we are the product that is being launched today, the B-Fluid. We have been using it at our hospital for more than 5 years, and I will show you what were our experience. So we know that 1/3 of patients who are admitted to the hospitals are malnourished or become malnourished when they exit the hospital. And it's also true that the surgical patients are also having this same problem. About 20 to 50% of the patients who came to the hospital is already malnourished. Now, we don't know which 50% of the patients, but we know half of the populations, especially in developing countries, are already not in the proper nutritional or good nutritional status. And as you can see that the Southeast and East Asia is more or less are affected of this problem. So in general populations, almost in Indonesia now we have a program of supplementing children with nutritional additional food for free for every students. And what we are trying to prevent is stunting, and stunting is about the problem, the malnutrition in the children. But this population, if they grow up and become adults, they also have still have a problem in nutrition. As I mentioned before, that in surgical populations, up to 61% is having this malnutrition problem. So nutrition is a critical and modifiable factors in surgical care. And we also know that it's already mentioned by the previous speaker that it has a major impact in the surgical outcome. We know that patient with malnutrition will have an increased risk of complications, increased risk of infections, and increased risk of mortality. In GI surgery, it's my specializations, we do, as I mentioned before, that we have a multidisciplinary approach, and we have perform multiple assessment for the patient, especially for major surgical surgery for preoperative, intraoperative, and postoperative patients. The previous speaker already mentioned about the enhanced recovery after surgery, and this does not start on the incision. So if we are applying ERAS, or enhanced recovery after surgery, we started right after the patient is decided to have surgery. So we started in the clinics. We try to assess the patient nutrition ability to move or to comply to instructions before the patient is admitted to the hospital. This is very important because if we start the ERAS when the patient is admitted to the hospital, it's already too late. Now, more of the concept of ERAS is doing prehabilitations, which we train the patient on how to manage their pain, on how to manage their diet, on how to mobilize after surgery before the patient is admitted to the hospital. The ASPEN guidelines is, as already mentioned, it's we do several steps. First, we do the screening. There are many types of screenings, the SGA, the MNA, and now one of the most popular one is the GLIM, which we assess the possibility also for sarcopenia for the surgical patients. And then after that, we do the assessment and diagnosis for grading the malnutrition status. After we assess that, then we do a surgical intervention. Now, the problem with this approach is that we don't really have enough time to do all of these things for all of the patients in the surgical ward. So what we are trying to do now is that we see, because of the high risk of malnutrition, we change our paradigm. We now think that we don't assume that the patient is in normal nutrition when they enter the hospital. We assume that they are malnourished when they enter the hospital. So now, if we change the paradigm that we consider the patient is already malnourished in the community before they are getting the surgical procedures, now we will be more careful in giving them what kind of nutrition, what kind of fluid, what kind of micronutrient to the patients when they are going to get the surgery. And we also assess the probability of the GI function disorder before we perform or before we do the surgery itself. So for example, if the patient is going to get a stoma for a rectal cancer resection, for an abdominal perineal resection, for example, we know that these patients might not tolerate the stoma itself, even because it's a new thing. So we know that the patient will have a problem in eating because he or she sees that there is a feces coming out of the stoma. So before we perform the stoma, we already educate the patients. So in order to get the better result after the surgery. So before the surgery, we do an education in types of, maybe we can tell the patient, okay, if you cannot tolerate having an feeding or enteral feeding, you can change your types of diet. For example, you can do milk, for example, or soft diet before returning to the normal diet. So we know that also surgical patients they need enough fluid, because and in many countries it's still that the patient has to have nothing per oral or fasting before surgery. Even though in our hospital we already tried to switch the protocols, as you can still have a solid diet 6 hours before the incision, and you still have clear water or clear fluid for 4 hours before incision. But in many practices, it still are not doing that. Sometimes the patient is having to have to fast overnight. Now, the problem of prolonged fasting is also the problem of insulin resistance. We have seen that in the previous talk. And if you put the patients in a prolonged fasting, then you will have a problem of insulin resistance after the surgery or during the surgery, which have a poorer prognosis for the outcome of the surgery. So now we move to the ERAS concept. Besides the problem of glucose metabolism, we also have a problem of immune modulation. So one of the problem of immune modulations in post-surgical patients is that there can be a problem of nausea and vomiting. We also know that the patient who have a problem in or don't have the enough amino acids given in perioperative period, even in the first 2 days, they will have started to have reductions in muscle mass. So as early as 48 hours after surgery, if you don't give enough amino acids or protein for the patients will start to have reduction in muscle mass. Now, if we acknowledge all of these potential problems, we can try to improve our patients' outcomes by using and addressing the metabolic and catabolic stresses associated with surgery. Of course, you can do this in a selective patient. You know that the patient is already malnourished, or you can do this in an assumed malnourished patient if you don't do the measurement. The problem of our practice, a lot of patients, is that we don't actually have time to measure one by one of our patients. Now, in the ERAS protocol, there are some use of parenteral nutrition because first, parenteral nutrition can facilitate timely nutrition when the patient is still having a nausea post-operative. You cannot give it per oral. Then these types of patients might benefit from parenteral nutrition. Of course, the rules still apply that if your gut works, it works properly, you still have, the best way is to give it orally. And if the patient is already after the surgery, we can do this using a partial parenteral nutrition as a bridge for a patient who have a post-operative complications. For example, a prolonged post-operative ileus. This patient cannot tolerate enteral feeding as early as possible. We know that the guidelines shows it should be in the first 24 hours. You try to give as early feeding as possible. In 12 to 24 hours, you can start giving food to the patient after surgery, not waiting for a bowel movement or not waiting for a passage of gas. Now, if we consider two things, first, you have the problem of glucose metabolism, which is disturbed because the patient is having fasting. The second one is the patient, even if the patient does not fast too long, the patient still needs an amino acids, because if the patient does not have this essential amino acids, it will just go, the reserve in the body will just go because the patient does not get intake from the outside. So we have this essential amino acids, which is mostly are the branch chain amino acids, the leucine, isoleucine, and valine. And this has to be provided daily, actually. Now, if the patient fasts, then the patient don't get these amino acids. So these amino acids also have a role in the synthesis of glutamine and alanine in skeletal muscles, which prevents our second problem, the sarcopenia problem of the post-operative patients. And it is already proven that the branch chain amino acid improves appetite. We want the patient to eat as soon as possible. Okay. This is also the studies that shows that higher branch chain amino acid has the benefit in reducing anorexia for the patients. The third problem is about micronutrient. We have a data that shows that thiamine deficiency is highly prevalent in hospital settings. For congestive heart failure, 50 to 90% of the patients have thiamine deficiency. For patients in the ICU, 71% is having thiamine deficiency. In the general surgical populations, it's almost 20% of the patient. So the problem with micronutrient like thiamine is that we measuring it's very difficult. It's in our center we still cannot measure the amount of thiamine. So you either have the symptoms, which is very late, or the patient looks okay, but having a thiamine deficiency. So we don't really we still cannot objectively measure the amount of thiamine in the blood. We know that the thiamine is have a crucial role in glucose metabolism. As we mentioned, the second problem, that is our metabolism, the glucose metabolism, and it acts as a cofactors for enzymes involved in Krebs cycles. So if the patient lacks thiamine, then you have a less efficient Krebs cycles. You have less ATP produced by the Krebs cycles. This is one of the studies that was performed quite a long time ago. It shows that after GI surgeries, 5 to 7 days post-operative, the amount or the level of thiamine in the blood is reduced below the necessary limit. So it reduces below 25 nanograms per milliliter. So if you have a post-operative GI patient and he has been hospitalized more than 5 days, it is very likely that these patients have thiamine deficiency. And if you can see in this graph, the amount of thiamine that is supplied by the fluids can cover or reduce the probability of thiamine deficiency in the blood. So without supplementations, you will get a drop of the 5 days. But if you give it in the first or before the operation, you can maintain the thiamine level above the necessary level in the blood. What are the benefits of thiamine? The first one is it prevents post-operative delirium, because we know that if you have a thiamine deficiency, you can have a Wernicke encephalopathy. It supports wound healing and tissue repairs. It reduces the possibility of lactic acidosis, and it protects cardiac functions because it maintains the nerve conductions in the cardiac nerves. And it is essential if you have a malnutrition and experience or a high risk of refeeding syndrome. So what are the risks? You know that thiamine have the risk of side effects if you have an allergy to thiamine. But in a very large studies, we don't see the incidence of the thiamine anaphylactic is lower than 0.1%. So in a large study, we see that there is no absolute contraindications, and the number of incidents increases with the level of the thiamine. If you give a bolus of thiamine, then you will have an increased risk of anaphylactic. But if you drip it slowly, the risk is much, much lower. So another micronutrient is zinc. So if we have a zinc, as you know, it's an antioxidant, and it's have a cytoprotective effect, and it has an anti-inflammatory effect. As mentioned by the previous speakers, we have surgery is an inflammatory induced procedure. So fasting induced inflammation, the surgery itself induced inflammation. So there is a benefit in reducing the inflammation after surgery. In post-operative nausea and vomiting, we know that it prevents the post-operative delirium. So if the patient can cooperate with you directly or as early as possible, then you can do the ARIFIN protocol. You can ask the patient to eat as soon as possible, and you can ask the patient to move as soon as possible, because we know that also movement is very important for post-operative patients. First, it induces the movement of the bowels, and the second, it prevents sarcopenia. So if you can get the patient to cooperate better rightly after the surgery, it's a good thing. This is a study in 2023 about fat emulsion and beef feed for gastric cancer. So you can see that in post-operative day 7, the loss of Branch chains amino acids is tended to be lower than the control group. But after 1 month, the loss of branch chains in the BCAA group is better than the control group. This is also the same study. This is for comparing the efficacy of the length of stay. So comparing to other types of fluids, it does not, it is non-inferior. This is a non-inferiority study. This is our experience for the, we collected the last 3 months data for 51 patients in general surgery. We give 1,500 cc's of B fluid per day as a maintenance fluids, and variation of surgeries between 1 to 3 hours. The patient is evaluated 24 hours after surgery. So we don't have any reported allergy or intolerance reactions to B fluid, and we assessed the quality of life using the Gickley 10 questionnaires. It's 0 to 4, and 4 is 0 is always and 4 is never. There is 10 questions, and as we can see that by giving this type of fluid, we see that most of the patients are on the right side of the graphic, which is higher Gickley score. So if you have a higher Gickley score, it means that their gastrointestinal symptoms are well tolerated. For the nausea and vomiting, it is also, we have a majority of patients who says that they don't have nausea and vomiting post-operatively. But we still have a problem in limiting or in the limitation of food consumption. So even though they don't have nausea or vomiting, our populations of the patient is still limiting the amount and the number, the amount and the type of the food that they are that their consumption after surgery. So I think this is my last slide. So we have these types of this fluid, B fluid. We do have the content is branch chain amino acid and vitamin B. And also, it also has some electrolytes and glucose, and it also has zinc in promoting tissue healing. So all of this in a double chamber. So it's a very, I think it's easier to provide to the patients. In conclusion is that these types of fluid, the B fluid consists of branch chain amino acid and vitamin B1 that is essentially, it's essential for a double action in combating fatigue and anorexia. And it is advanced solutions. It's ready to use formulations. So there is lower risk of compounding errors. The inclusion of vitamin B1 can cover the fatigue and post-operative nausea and vomiting. B fluid is also indicated for support in intensive care and having a balanced calorie, not fasting the patient. So actually, if you read or follow the ERAS protocol, there are suggestions to give pre-operative carbohydrate loading, which is an oral carbohydrate using the gastrointestinal tract before the patient fasts for surgery. But the problem is that this type of carbohydrate is specifically formulated. It is not available, and not all of the anesthesiologists agrees that you can give it 4 hours before surgery. They wanted the patient to be more safe to fast longer, actually. So if this happens, then you need to have an alternative of giving calories or glucose to the patient as so that the patient does not have to fast too long. Thank you very much for your attention.
Thank you, Dr. Franz, for sharing your valuable experience. Now, we will move into the Q&A session. So I kindly invite to our chairperson and also all the speakers to join us on the stage to take part Q&A. So we now open the floor to questions from the audience.
Now the floor is open for Q&A section. Any questions from the floor or any experience sharing from the floor? Sia Wimo, nutrition specialist.
Thank you very much. Okay, I think it's a very comprehensive topic. I don't need to discuss much. But only one thing I want to know the situation is, and the first speaker, Professor Sang, and the last from the Indonesia. The problem is we have a fasting period. Now quite okay in our private setting, maybe 6 hours for the general surgery, major surgery, and then like hernia surgery, 4 hours okay, minus 2 to 3 hours quite okay. But the problem is that pre-operative recovery loading is quite problem in our country, especially from the anesthetic aspect. They don't quite agree 2 to 3 hours before taking the glucose. This is one problem in our country at the moment. That your beef is very good with the glucose B1 minus very, very good. I want to know is it still hypotonic or isotonic or tonicity aspect? Is it more acidic or is it alkali? For example, normal saline is acidic, reality is alkali. What about the osmolality and acid base? If we use not just one body, no problem. If we use more and more, so is this acidic or alkali side? Is it still hypotonic? Every glucose is hypotonic. 5% is hypotonic. But what is minerals and magnesium, phosphorus? Is this isotonic or hypotonic? So we are some cases like the major surgery are quite complicated. What do you think? These sort of things. That's the question.
Could you please answer? The B fluid is isotonic.
Sure. I'm not sure about the tonicity. You will have to ask the producer. But the osmolarity, which is concerns usually because we give it peripherally, is less than 800. So for me, I never have a patient who have a phlebitis or thrombophlebitis in giving 1,000 to 2,000 cc's of B-fluid in 24 hours. Some of our colleagues in Indonesia experienced this, that if you give it more than 2,000 cc's, then it's very fast. So it's quite fast. So they have a higher risk of thrombophlebitis. About the tonicity, I'm not quite sure. Maybe maybe there's a presentation from the, but the osmolarity is well suited for periphery infusion.
I think it might be not more than 900 milli osmo. I'm sure.
I read about that
Yeah.
In the literature.
How much?
It's 850 million.
Yeah, quite high.
Yes,
Because
it is
our
high.
normal saline as said around around about 300.
Yeah.
So a little bit high. I'm saying that. It's a one bottle not has no problem. It's a more and more. Many fluid or many days. Quite what do you think about that? Thank you very much.
I'm very agree with Professor Wilmon for fasting, for not only in surgery but also for endoscopy. We need a fasting, but we don't want to. We are afraid of prolonged fasting. But sometimes we have to discuss with our anesthetic. I think we have anesthetist. So anesthetist is agree or not. So I think we have a lot of anesthetic in the audience. So what about the fasting? So we nowadays the practice change, solid food fasting for 6 hours, and liquid food can fast up to 2 hours. So most of the surgeons and GIs agree, but some anesthetists are still reluctant. So what do you think for that fasting new idea? That's a chance from audience.
Thank you, Shay. And for the fasting, there is a clear guideline for the fasting. Solid food for 6 hours and clear fluid for 2 to 4 hours. 2 to 4 hours. But in some condition, there is maybe a prolonged delay gastric emptying, or there may be the intestinal obstruction or like that. We have to careful about the aspiration. So we have to strictly very strict on the fasting guideline. But there is a study and carried out in the Yangon General Hospital done by the one anesthesiologist. They measure the stomach and according to the stomach volume according to the fasting. There is no evidence of increased stomach volume. That means the we can safely use the fasting guideline according to 6 to 4 hours. So for the endoscopy also we usually use the guideline. It is also aligned with the international guideline. So we are still obeying that guideline. Solid food for 6 hours and liquid food for the clear fluid for 2 to 4 hours. Thank you.
And thank you, sir. For fasting now, another problem with a new anti-obesity and new diabetes drugs, SGLT1 antagonist. For that, it can delay the gastric emptying time. So there's a lot of drugs, but not a true guideline. There are so many drugs. For if patient use that drugs, some surgeon or gastroenterologist to change other drug before the procedure, or change the diet, a semi-solid diet for 2 or 3 days, and then liquid diet. Some center they ask to do pre-procedure ultrasound to know the gastric content in such kind of case. But in our country now we have new drugs, so a lot of interest, but we have to aware that drugs can delay gastric emptying time. Thank you. Is there any question from audience or comments or from online? I also want to touch our teacher, Professor, who thinks so. So any comments about nutrition in GI or surgery CI? Shall think so.
ကျွန်တော်ဟိုးအရင်တော့ပေါ့လေပို့ဆော့ပါမှာ normal saline တစ်လုံးဒီသုံးလုံးနဲ့သွားကြတာပေါ့လေအဲတော့ဟိုပါ calories ပဲနည်းနည်းပဲ calories မှမပြည့်ပါဘူးဆရာ glucose တစ်လုံးကခုနက5 gram ဆိုတော့15 gram ပဲပို့ဆော့နေတဲ့ကတော့ starvation period ပေါ့အဲ့ဒီကနေပြီးတော့နောက်တော့အဲ့ဒီ protein supplements ပါတယ်ပေးကြတာပါလေအဲ့ဒီမှာAmino acid infusion တစ်လုံးထည့်လိုက်ဟိုထည့်လိုက်နည်းနည်းပဲကျွန်တော် supplement အခုဒီ B fluid လာတော့လေကောင်းတာပေါ့တော့ is it from the Indonesian practice you use only B fluid for the post operative period 1500 cc per day is sufficient do you not use dextrose water or normal saline or dextrose saline so the B fluid is it a new drug with how much vitamin B1 and how much amino acid and how much glucose?
Oh, okay. Okay. Yeah. Okay. No. So, in our practice, we use it. This is only for the first 48 hours of surgery. So before the patient fasts, and then if the patient can tolerate food in the 24 hours after surgery, then we still give fluid until the patient is discharged. But if the patient cannot tolerate additional caloric intake after the surgery, then we need to reconsider on the 48 hours after the surgery, either to change the type of fluid or to add something else, something more. So you can give, for example, you can give lipid into the beef fluid, or you can have the other types of parenteral nutrition. So basically, our target is in the 4th to 5th post-operative day, the patient has already have 80 to 100% of the necessary calorie, whether the patient is in the ICU or the patient is in the ward. So in the 4th to the 5th post-operative day, the patient should have 100% of the calorie. That is why we calculate usually after 48 hours. So patient gets the fluid, then surgery, then after 48 hours, we reassess whether you should switch or you should add something to the maintenance fluid. I think hopefully it answers the question. Thank you.
Yeah. So when the Otsuka people come to ask me to organize this meeting, then I said beef fluid. So when we consider about nutrition, carbohydrate, fat, amino acid, vitamins, minerals, something like that. But why particular B1? I asked myself. But now that Dr. FRANSISCUS has mentioned about this, so I just want to ask you, so you have used it, you have experiences, how good it is in your experience? How beneficial is it? Because it's B1 alone. And
so we have a study running, ongoing, Professor. So the part that I have shown you that in this 51 samples, we don't have any complications. That's the first thing, because we added something, right? So we want to know whether what we add is safe enough. And we don't have any complaint or complications. The second one is this is only a post-op or post-op study, so only one measurement with like to expand it in the next 2 or 3 months to have a pre and post intervention comparing this type of fluid and additional fluid, the thiamine, to the regular electrolyte only fluid without any additional sugars. So it's still ongoing because the number of the samples are not enough to make a comparison. But what we see in the post-op studies only, we have a lot of patients that don't have gastrointestinal complaint. So they don't have the nausea, they have less vomiting, they do pass the gas faster, and that means that they can be mobilized faster and they can have this enteral feeding faster. So we don't have the absolute data. If we want to compare it, maybe in the next 6 months, hopefully. But now our study just shows that post-operative patients have higher satisfaction, if you want to say, in the gastrointestinal complaint. I think that's a temporary answer, Professor.
Nutritionist.
Nutritionist. Thank you.
I'm Dr. Wins and I'm nutritionist. So first of all, I would like to say all congratulations and thank you for your all presenters and chairpersons. So in our countries, nutrition is very important for every patient, but in surgery fee, we give a nutrition intervention for post-operated patients only. So because of the all surgeons needs to refer pre-operative surgery intervention, pre-operative nutrition supports. So at first we give parenteral nutrition, glucose and normal saline. But in this moment, so we have to use amino acids. Sometimes we need lipids and then TPNs. So as you mentioned, Professor Sanji, so that is very important for pre-operative nutrition supports. So IRADS say that. So we have to use, nowadays we use amino acids, so that including vitamin B1. So that is a very important and essential for so many patients. So I'm very proud and very I say to thank you. So also, so nowadays we have so many types of parenteral nutrition, and then we have to use and we have to choose parenteral nutrition. So it's very good for our patients. Thank you.
There are written questions from the audience. So one is to Professor Sanyi. How to monitor goal-directed fluid therapy in general surgery? Transesophageal Doppler, CVV line are not practical. What is this? Do you have any experience with goal-directed fluid therapy?
Thank you for question, and it's a very good question. I have mentioned I already mentioned the esophageal Doppler ultrasound is a limited option in our country, but not CVV line. I have a little experience of goal-directed therapy together with intensive phase, our intensive phase. After major surgery, we keep the patient in the ICU together with CVV line, so we can treat according to the goal-directed therapy.
There's another question. Can we use B fluid in sarcopenia patients? So we have no answer. I think no.
Sure. Okay. So first you have to recognize sarcopenia. This is a big problem actually. So there is a GLIM criteria, and in measuring sarcopenia is a big problem. But we know that if you do not give any amino acids, any protein on the first 48 days, sarcopenia will start. So first, recognizing sarcopenia is very important. You can a lot of things. The easier one is just to measure the diameter of the calf muscle, but the more is the muscle strength. You can use the dynamometer to measure the muscle strength, or there are some software that can count for us in the GI surgery. See the size of the muscles in the abdominal area, and put it inside the software, and it will measure the amount of the muscles there. So no, I don't recommend only giving beef fluid as a treatment for sarcopenia. It is not enough. First, sarcopenia happens because of two things. One, because of the mobilization of protein. So it's after the patient goes to surgery or in the critical care, there's a catabolic state. They use all the protein for energy. So you cannot replace only the protein. You need to have enough energy so that the protein is not utilized for energy. So first you need to count enough calorie, and beef fluid will not give you enough calorie in the amount of volume that you can give it. So you need to count the calories, and some of the calories will come from fat. So fat is, then the density of calorie in fat is higher. It's 9 calories per gram. So you can give a lower volume with higher calories. First, you need to give 100% of calories. And then now there's a big question whether you give low protein, regular protein, or higher protein. So the last study, I think in 2024, shows that if you give high protein, it just it does not help sarcopenia, because there is higher metabolic rate, higher metabolism that is necessary to digest the protein. And it does not store the protein into the muscle. It does not create the muscle mass. So either you give a baseline protein, or a little bit lower than baseline is better for the sarcopenia. The solution is to move the muscle, because if you move the muscle will store protein and create some more muscle mass. So the patient should have an exercise, not only given protein, but also an exercise. Now, exercising the patient is one of the cornerstone of ERAS. So you want, that is why I mentioned before, prehabilitations or training the patient before the surgery is a good thing. So the patient knows, okay, after surgery, I am required to sit down. I am required to move around. And I can do this with this help or this assistance or something like that. So as early as the patient recover from anesthesia, if the surgery is about abdominal surgery, it's not the ankle or foot or something movement area, then you can push the patients to move. If the muscle moves, it saves it reduces the incidence of sarcopenia. Of course, give adequate nutrition, and then move the muscle, exercise the muscle. I think that answers the questions. Thank you.
The last question is, are there any role of probiotics and microbiomes, fecal transplantation in the management of inflammatory bowel disease? Professor Symposium, please.
The guidelines recommend that in the Crohn's disease, the probiotics are not usually recommended. They cannot induce the remission and can cannot maintain the IBD activity. But in the ulcerative colitis, we can give the probiotics like the Lactobacillus reuteri and VSL3. We can give in ulcerative colitis. So what about the prebiotics? The prebiotics is usually that food that contain in the fibers. So we can give the prebiotics in IBD patients with some like the constipation. So we can use the prebiotics in that kind of patient. So what about the fecal microbiota transplant in the inflammatory bowel disease? And we can try the FMT in IBD, but the guidelines, in the guidelines, the FMT is not usually recommended.
Fecal FNT, the usual, the guideline usually allow for the difficult seated infection is a proven fact. Others are still on ongoing trial, IBS or IBD or so many obesity or so many things. But real guideline is FND is mainly for the difficult seated infection.
There are some more questions from the floor. One is, what diet plan is best for D2 gastrectomy of adenocarcinoma stomach? Vitamin B12, B1 plus protein supplements for this patient. Dr. Gigi Kaine. Yeah, sure. D1 gastrectomy.
It's also another good question. Normally, after D2 gastrectomy, we usually done a T2 gastrectomy, subtotal or total gastrectomy. So the patient will need nutritional support in the postoperative period. And as per after distal gastrectomy, there is a loss of intrinsic fat. So there's absorption of impairment of vitamin B12, but not B1. But in the post-operative period, we have to support nutritional support, especially in the early period, parenteral nutritional support, and later oral nutrition is the best, including you can use in the early post-operative period, B fluid. And in the post-operative, later on that, you can use the amino acid powders like you already know, Ensure or Glucina, or and then Prohance HP.
Another question is there any allergic reaction, B1, amino acid, glucose, Dr. Swetian? What about allergic to B1?
Yes, there is a report to B1 allergic reaction, but for not for the B fluid, not for the, because the amount of B1 is correlated with the risk of anaphylactic reaction. So if you give a bolus B1, for example, for patients with reduced consciousness in the ER, you don't know what happens. There is a protocol of giving a high dose of B1. This have an incidence of 0.1%, I think, for anaphylactic reaction. Now, if it is given in drip, in a small, very small dose, we don't have the report of allergic reaction to B1 if given in this way. We don't know because it's you need a lot of study for a longer period of time to really say. But of course, and as with all supplements, do not give it to people who have recorded reaction or anaphylactic. It's the same. Vitamin C, any vitamin additional have the potential of allergic reaction.
I'm not very sure about this B1 alone reaction or not, because in our country we are using a multivitamin, and when we use multivitamin, it includes all B and other things, nicotinamide as well. So we experience some cramps in the abdomen or some flushing or some hot flush, something like that we experience. I don't know whether it's contributed to B1 alone or the other vitamins. Because what about cell DNA?
So So every doctors we are worried about the anaphylactic reaction, especially antibiotic or vitamin. But in our day-to-day practice, when we ask allergy, most of the patient they have the experience of allergic to Bablex. So Bablex allergy and B1 allergy is a totally different. So Bablex it contains B1, B2, B6 plus niacin. So most of the patient after taking Bablex, they complain of flushing of face, and that's not due to B1, it's a niacin. Niacin is a vasodilator. So real incidence of B1 is really rare because we use a lot of multivitamin B1, B6, and B12 for so many cases, neuro or other reason. But in real practice, so B1 hypersensitivity is a very rare, but we have to aware, and before discuss, we have to ask the patient for any allergy to vitamin, including B1 before giving B fluid. Is there any question?
Is there any question? So before closing the Q&A session, I would like to invite Mr. Arif. So is there any comment regarding the product for the osmolarity and then any other product related questions?
So thank you. My name is Arif from Otsuka, Indonesia. So based on our discussion, I would like to giving some information that regarding to the question about the tonicity. Of course, if we refer to the presentation that Professor, the isotonic, the range is 30, 100, under 30, 150 milliosmol. So the B-fluid itself, for the osmolarity, more or less the specification of product 850. It's mean this is the hypertonic. So the refer to the guideline, there are some, of course, the issue, is it okay, utilized by or administration by peripheral or central vein? The guideline said that the upper limit for the peripheral still below 900 milliosmol. It means still appropriate and utilized by peripherals. Of course, as long as we marketed B-fluid Indonesia, there are some very few or very small accident like phlebitis or pain. Of course, depend on the patient condition. If the patient like there are some facing some this issue, we always giving some countermeasure, like we giving the slow drip, the maintenance. It means sometimes we can utilize not 6 hours, but we can extend like 8 until 10 hours. This is the first point. For the second point, of course, it will be correlated based on osmolarity with the pH. For the pH itself, as the product, more or less as a specification is 4.5 until 5.5 pH. It means slightly acid. Of course, it will be risk of the pain. I think for the almost the parenteral, the pH more or less slightly acid. I think both of them it will be should be considered depend on the patient condition, and we should monitor whether the patient become like a pain or there are some issue of the phlebitis. To be honest, Indonesia, of course, they facing some this issue also, but we can monitor and solve this problem depend on the patient condition. I think that's all for our side. Thank you.
Thank you, Mr. Arif, for your comments. So now it's time to close the Q&A session. So thank you so much, our professors, speakers, and also the participants for the engaging session. So now we move to the product presentation session. It is our pleasure to welcome Nila Jo, Group Product Manager from Otsuka.
Okay.
First of all, I will present with my local language. Thank you. ပထမအောင်ဆုံးအနေနဲ့ပေါ့နော်ဒီနေ့ဒီ Be Fluid New Launch လေးကိုကြွားရောက်လာပြီးတဲ့ our Chairperson Speaker နဲ့နောက်ကိုရီမားတွေဆရာတွေအားလုံးကိုကျေးဇူးအထူးတင်ရှိပါတယ်လို့ကျွန်တော်ဥစွာပြောကြားလိုပါတယ်။ product အကြောင်းလေးကလည်းဒီဆရာတွေနဲ့လည်းတော်တော်များများလည်းပြောပြီးသွားပြီဆိုတော့ညီလာကဒီ product ရဲ့အသုံးပြုပုံလေးနဲ့ပေါ့နော်သူ့ရဲ့ composition လေးနည်းနည်းလေးရှင်းပြချင်ပါတယ်။ အဲ့တော့ B fluid ကတော့သူ2 chamber double chamber နဲ့လာတယ်အဓိကအားဖြင့်တော့vitamin B နဲ့ electrolyte တွေပါဝင်တာဖြစ်တဲ့အတွက်ကြောင့်မို့လို့သူ့ကို B fluid လို့နာမည်ပေးထားတယ်ပေါ့နော်အဲ့တော့ electrolyte glucose နဲ့ amino acid နဲ့ B1 ဆိုပြီးပါတဲ့အတွက်ကြောင့်မို့လို့အရှိမှလည်းအများကြီးရှင်းပြပြီးသွားပါပြီအဓိကတော့ hospitalized patient တွေရဲ့ improvement အတွက်ကိုဒီ chamber လေးကိုသွင်းလာတာဖြစ်ပါတယ်ဒီ infusion လေးပေါ့နော်အဲ့တော့ပထမဆုံးအနေနဲ့သူက double chamber ဖြစ်တဲ့အတွက်ကြောင့်မလို့ဒီအပေါ်ဘက် upper chamber မှာဆိုလို့ရှိရင်တော့ BCAA ပါဝင်ပြီးတော့lower chamber မှာဆိုတော့ glucose နဲ့ some electrolytes တွေပါဝင်ပါတယ်အဲ့တော့sodium ကသူ့မှာ35ပါတယ်နောက်တစ်ခုကကျတော့ glucose အနေနဲ့တော့75 gram ပါပါတယ်နောက် BCAA အနေနဲ့တော့9 gram ပါပါတယ် other general BCAA ထက်ဆိုလို့ရှိရင်တော့အနေငယ်များတယ်ပေါ့နော်နောက်တစ်ခုကကျတော့ခုန B1 ပေါ့ thiamine equivalent အနေနဲ့ဆိုရင်တော့ 1.5 mg ပဲပါပါတယ်ဆိုတော့ very small dose ဖြစ်ပါတယ်အဲ့တော့ B1 allergy အတွက်ကိုစိုးရိမ်စရာအရင်မရှိပါဘူးနောက်တစ်ခုကတော့ osmolarity ပေါ့နော်ခဏကလည်း Mr. Eric လည်း already mention about that 850 osmolarity ဖြစ်ပါတယ်အဲ့အတွက်ကြောင့်မို့လဲစိတ်ချလက်ချ drip ကိုအသုံးပြုလို့ရပါတယ်အဲ့တော့ဒါကတော့သူ့ရဲ့ chamber လေးကိုရှင်းပြထားတာပါ upper chamber မှာတော့150 ml ပါဝင်ပါတယ် amino acid နဲ့ some electrolyte ဖြစ်တဲ့phospholipid နဲ့ sodium တို့ပါဝင်ပါတယ် lower chamber မှာတော့ glucose နဲ့ vitamin B1 နဲ့ electrolytes ကို350 ml ပါဝင်ပါတယ် all together ဆိုလို့ရှိရင်တော့500 ml ရရှိမှာဖြစ်ပါတယ်အဲ့တော့အသုံးပြုပုံကတော့ဒီလိုလေးပေါ့နော်သူကတော့ double chamber ကိုခောက်ရလေးလာပါတယ်အပြင်မှာ plastic bag လေးလည်းရှိတယ်အဲ့တော့အဲ့ plastic bag လေးကိုဖွင့်ပြီးလို့ရှိရင်ဖိဖို့နေရာလေးပေါ့နော် hands ပုံလေးပါထားပါတယ်အဲ့နေရာလေးကိုဖိလိုက်လို့ရှိရင် chamber လေးပွင့်သွားပြီးတော့အပေါ်နဲ့အောက်နဲ့ mix လုပ်လိုက်ရမယ်ပေါ့နော်သေချာ mix လုပ်လိုက်ပြီးလို့ရှိရင်ချက်ချင်းdrip ချိတ်လို့ရပါပြီအဲ့တော့ drip ချိတ်ခံနေမှာပဲ mix လုပ်ဖို့လိုအပ်ပါမယ်အဲ့လိုမဟုတ်ဘူးဆိုလို့ရှိရင်တော့ reaction တွေရနိုင်တဲ့အတွက်ကြောင့်ပါနောက်တစ်ခုကကြတော့သူ့ရဲ့composition တွေပေါ့နော် glucose အနေနဲ့လည်းသူ့မှာ75ပဲပါတာဖြစ်တဲ့အတွက်ကြောင့်မို့လို့ဒီ hyperglycemia ဖြစ်ဖို့လည်းအများကြီးလျော့နေစေပါတယ်နောက် first surgery အနေနဲ့ဆိုလို့ရှိရင် glucose တွေအများကြီးအတွက်လည်းမသင့်တော်တာဖြစ်တဲ့အတွက်ကြောင့်မလို့75 gram ပဲသူမှာပါရှိပါတယ်နောက်တစ်ခုကကျတော့ amino acid 30 gram နဲ့သူမှာ BCAA 9 gram ပါဝင်တဲ့အတွက်ကြောင့်အဓိက patient recovery အတွက်ကိုအမြန်ဆုံးဒီ day 7 အထိမှာပေါ့နော်အမြန်ဆုံးပြန်လဲ recovery ရဖို့အတွက်ကို support ပေးပါတယ်နောက်တစ်ခုကတော့ sodium ပေါ့နော်sodium လေး35ပဲပါတာဖြစ်တဲ့အတွက်ကြောင့် warm healing ကိုdelay ဖြစ်စေတာကိုလည်း prevent လုပ်ပေးပါတယ်နောက်တစ်ခုကတော့အခုinjection ကတော့500 ml ရှိပါတယ်ဒီ Indonesia မှာဆိုရင်တော့သူက2မျိုးလုံးလာတယ်ပေါ့နော်500ရော1000 ml ရောပါအခုလက်ရှိသွင်းထားတာတော့500 ml ပဲဖြစ်ပါတယ်အဲ့တော့ dosage အနေနဲ့လည်းပုံမှန် drip သုံးနေကြdose ပဲဖြစ်တဲ့အတွက်ကြောင့်မို့လို့အချိန်အများကြီးလည်းပေးစရာမလိုဘူးပုံမှန် drip ချိတ်တဲ့timeline တိုင်းကိုပဲသုံးလို့ရပါတယ်နောက်တစ်ခုကကျတော့သူ့မှာအားသာချက်တွေကနောက်ထပ် electrolyte တွေပါဝင်တာဖြစ်တဲ့အတွက်ကြောင့်မို့လို့zinc ဆိုလို့ရှိရင်လည်း warm healing အတွက်ကို support ပေးတယ်နောက်တစ်ခုက electrolyte တွေပါတာဖြစ်တဲ့အတွက်ကြောင့်ဒီ hospitalized patient တွေအတွက် electrolyte imbalance အတွက်ကိုလည်း support လုပ်ပေးမှာဖြစ်ပါတယ်နောက်တစ်ခုကဘာလို့ဒီ B1 ပေါ့နော် B1 only ကိုပဲသုံးထားလဲဆိုလို့ရှိရင် B1 ဆိုလို့ရှိရင်ခုနကဆရာကြီးလည်းအများကြီးရှင်းပြပြီးသွားပါပြီအဓိကပေါ့နော် post operative မှာ0 to day 7 ထိမှာဆိုလို့ရှိရင် thiamine deficiency ကတော်တော်လေးကိုများပါတယ်အဲ့အတွက်ကြောင့်မလို့ vitamin B1 ကို support အနေနဲ့ထည့်ပြီးထားတာဖြစ်ပါတယ်အဲ့အတွက်ကြောင့် thiamine deficiency ကိုsupport လုပ်ပေးဖို့ဖြစ်ပါတယ်နောက်တစ်ခုက vitamin B1 ကတော့ခန္ဓာကိုယ်ထဲမှာ store လုပ်တာ very small limit amount ဖြစ်ပါတယ်အဲ့အတွက်ကြောင့်မို့လို့ဒီတက်အပြင်ကနေပြီးထပ်ပြီးတော့ oral အနေနဲ့ supplement အနေနဲ့ထပ်တောင်းရမယ့်အစား drip ထဲမှာတစ်ခါတည်းပါပြီးသားဆိုလို့ရှိရင် already patient တွေအတွက်ကို compliance ကောင်းစေဖို့အတွက်တစ်ခါတည်းကို ပြင်ဆင်ပြီးတော့လုပ်ပေးထားတာဖြစ်ပါတယ်အဲ့အတွက်ကြောင့်မို့လို့ဆရာတို့ကိုရိုမာတို့ရဲ့ဒီ surgical care patient တွေအတွက် supported အနေနဲ့ဒီ B fluid လေးကိုတင်သွင်းလာတာဖြစ်ပါတယ်အခုလက်ရှိမှာတော့ဒီ amino acid infusion တွေလည်းရှိတယ်ဘာကြောင့် double chamber ဖြစ်နေလဲဆိုလို့ရှိရင် normal ပေါ့နော် mild to moderate normal amino acid အတွက်ဆိုလို့ရှိရင်เนาะရိုးရိုး amino acid တွေအတွက်လိုအပ်တယ်လို့ဒီခုလိုမျိုး hospitalized patient တွေအတွက်ကြတော့ပို့ပြီးတော့သူက electrolyte ကော glucose ကောနောက်ပြီးတော့ vitamin B ရောလိုအပ်တာဖြစ်တဲ့အတွက်အဲ့ဒီ gap လေးကိုဖြည့်ဖို့အတွက် B fluid ကိုတင်သွင်းလာတာဖြစ်ပါတယ်အဲ့တော့ဒါကတော့ thiamine deficiency တွေလည်းဒီ case တွေမှာအများကြီးဖြစ်တယ်ဆိုတာတော့အရှိမှပြောပြီးသွားပြီပေါ့နော်နောက်တစ်ခုကဒီဟာလေးကိုလည်းနည်းနည်းရှင်းပြချင်ပါတယ်အဲ့တော့ဒီ Otsuka Indonesia မှာဆိုရင် already have Panamine G injection လည်းရှိပြီးသားပါအဲ့တော့ Panamine G အတွက်ဆိုလို့ရှိရင်เนาะဟို mild to moderate ဒီ operation patient တွေအတွက်ကိုလုံလောက်ပါတယ်အကယ်၍ခုနလို severe to mild to moderate ကနေ severe infection တွေဖြစ်မယ် vitamin B လည်းလိုအပ်မယ် electrolyte တွေလိုအပ်တဲ့ patient တွေအတွက်ဆိုလို့ရှိရင်တော့ B fluid ကိုထပ်ဆောင်းပြီးတော့အသုံးပြုလို့ရပါတယ်အဲ့တော့ဒါနောက်ဆုံးချက်အနေနဲ့ဆိုလို့ရှိရင်တော့ B fluid ရေအားသာချက်လေးတွေပေါ့နော်ခုနက double chamber ဖြစ်တဲ့အတွက်ကြောင့်မို့လို့ double action support လုပ်ပေးမယ်အဓိကတော့ hospitalized patient တွေအတွက် vitamin B supported အနေနဲ့ရောနောက်ပြီးလို့ရှိရင်ဒီday 7အတွင်းမှာမြန်မြန် recovery ရဖို့အတွက်ကို B fluid ကိုအသုံးပြုလို့ရပါတယ်နောက်တစ်ခုကကျတော့ခုနလိုပေါ့နော် B complex ကိုစိုးရိမ်စရာတော့မရှိဘူးသူမှာ B1 only ပါတာဖြစ်တဲ့အတွက်ကြောင့် B1 allergy ကလည်း very rare case ပါနောက်တစ်ခုကကျတော့သူ့ရဲ့ composition ကလည်းdose ပမာဏအရင်မများတာဖြစ်တဲ့အတွက်ကြောင့်မို့လဲစိတ်ချလက်ချသုံးလို့ရပါတယ်နောက်တစ်ခုက amino acid အပြင် BCAA လည်း9 gram ပါဝင်တာဖြစ်တဲ့အတွက်ကြောင့် patient ရဲ့ recovery state ကိုပို့ပြီးတော့ supportive ဖြစ်အောင်လုပ်ပေးမှာဖြစ်ပါတယ်အဲ့တော့နောက်ဆုံးအနေနဲ့ကတော့ဒါ packaging အနေနဲ့ကတော့500 ml လာပါတယ်ဈေးနှုန်းအနေနဲ့ကတော့94,250ပါအဲ့တော့ဒီ Otsuka Indonesia မှာဆိုလို့ရှိရင်เนาะပြောရမယ်ဆိုရင်ဒါ first brand အနေနဲ့ဆိုလို့ရှိရင် Panamine G amino acid အနေနဲ့ရှိပြီးသားပါအဲ့ဒီပြင်နောက်amino liban ကတော့ liver ပေါ့ HC patient တွေအတွက် supported အနေနဲ့ specialize အနေနဲ့ထုတ်ထားပါတယ်နောက်တစ်ခုကတော့ kidney မှာဒီကတော့ဒါ KD patient တွေအတွက်အဓိက supported ပေးတာပါအခုနောက်ထပ်ရောက်ရှိလာတာတော့ B fluid ဖြစ်ပါတယ်ဒီကတော့ hospitalized patient တွေအတွက် vitamin B electrolyte နဲ့ amino acid glucose တို့လိုအပ်မယ်ဆိုလို့ရှိရင် B fluid ကိုရွေးချယ်လို့ရတယ်လို့ပြောကြရင်နေကုန်းချုပ်ပါတယ်ကျေးဇူးတင်ပါတယ်ရှင်
အားတော့ beginner တွေ order ပြီးပါရှင် ဘာသာသက်သက်တဲ့ question လေးတွေရှိတယ်။ပါပြီးတဲ့လို့ရပါတယ်နော်။ To conclude today's program, may I invite Professor THEIN to deliver the closing remarks. Please give him a warm welcome.
Everybody is hungry. And dinner is ready. So I try to make a conclusion remarks as short as possible. I make it two page, but I cancel one page. So for the short one. So thank you very much for attending today's scientific symposium in person or online. So I also thanks who participate actively during the session. And I'm very proud to be chair together with my teacher and my senior Professor Utungu. I learned a lot from three speakers. So Professor Usanyi, Professor Srimomya, and Dr. FRANSISCUS from our Indonesia friends. So we learned a lot from three speakers. I also like to thank the TKSH Myanmar for such kind of scientific symposium for important nutrition. So we learn nutrition is a multidisciplinary approach, pre-operated, during operation, post-operated, and a lot of factor about nutrition. Also thanks Osuka, Indonesia, for such kind of good essential fluid to import it into Myanmar. So last but not the least, I really thanks all the audience up to the end of today's symposium. So thank you, everybody. Thank you.
Thank you, Sia. And Sia, please remain on the stage to get the cake ceremony. Cake cutting ceremony. Sia, please remain on the stage. And it's time to celebrate the launch of B-Fluid product. So I would like to invite our chairman and all the speakers to the stage for the cake cutting ceremony. So we are delighted to announce that B-Fluid is now available in Myanmar. Let us give a final round of applause to celebrate this moment. Thank you very much, our distinguished chairperson, our speakers. We now invite you to enjoy dinner and continue networking, wishing you a pleasant evening. Thank you.